Previously আমি তোদের বলেছিলাম about different types of lung infections, like so one is pneumonia and tuberculosis, ঠিক আছে? So now let's discuss about pleural diseases. So there are two main pleural diseases to discuss. One is pleural effusion and another one is pneumothorax. So what is pleural effusion? Excess amount of fluid accumulation between the two layers of pleura. This is called pleural effusion. But what is pneumothorax? Any amount of air accumulated in between the two layers of pleural, two pleura, visceral and parietal. So mind the language and definition. One is pneumothorax, that means any amount of air. So there is generally no amount of air in normal condition, there will be no amount of air, right? But in case of pleural effusion, excess amount of pleural fluid. That means some quantity of pleural fluid is normally present in between the two pleural spaces, right? So this is pleural effusion and second one is pneumothorax. So now briefly let's discuss about the pleural anatomy. So what are the two pleura, two layers of pleura, and one is parietal and another one is visceral pleura. So what is visceral pleura? That means the pleura that lines the lung parenchyma and the lung fissures, that is called as visceral pleura. And what is parietal pleura? There is covering the outside of the lung and outside of the visceral pleura, that is parietal pleura. So parietal pleura can be classified in three layers of parietal pleura. One is costal and another one is mediastinal, that covers the mediastinal structures, and the third one is diaphragmatic, covers the diaphragmatic part of the pleura. So this is the anatomy of pleura, right? So what is the blood supply of pleura? The visceral pleura gets the blood supply directly from the bronchial circulation, just as like the lungs. But in case of parietal pleura, the costal pleura and the mediastinal pleura receives blood supply from the intercostal arteries, whereas the diaphragmatic pleura receives the blood supply from the pericardio-phrenic artery, right? And about the nerve supply, so which has got more nerve supply, parietal or visceral? Any idea? So which is painful? Which pleura, if you injury any pleura, which pleura will be painful? Parietal pleura. So the parietal pleura has got many denervations, such as intercostal nerves are there, and the diaphragmatic pleura is innervated by the phrenic nerve, but the central part of the diaphragmatic pleura, not the peripheral part. Peripheral part are also from the same intercostal nerves. So as I have already mentioned in my introductory lecture, that is small amount, that means 8 to 12 ml of pleural fluid normally present in between the two layers of pleura, right? So which acts as a lubricant, so which prevents the friction when you inspire deeply or cough. Normally the pleura rubs together, right? But to prevent the friction, there is a lubricant, that means pleural fluid is present. So the normal amount is 8 to 15 ml, right? Okay. So what are the different mechanisms of pleural effusion? Any idea? So we all know there are two different capillary pressures. One is oncotic and another one is hydrostatic pressure, right? So what is oncotic pressure? Actually, easily we can say that the oncotic pressure pulls the fluid inside the capillary, whereas the hydrostatic pressure pushes the fluid outside the capillary. Okay? So if the pulling of the oncotic pulling is less. That means the fluid cannot enter into the capillary. So the fluid will be outside the capillary and it will be accumulated in pleural space. That means reduction of the oncotic pressure. So oncotic pressure mainly driven by which protein? Albumin. Albumin is the main driver of the oncotic pressure. So if in case of hypoalbumin state, suppose the patient is having nephrotic syndrome, that means the protein production is sufficient, but there is excretion of the protein, albumin. That means one is nephrotic syndrome, where there is less oncotic pressure. Second one is liver failure, where there is less synthesis of the albumin. And third one is malignancy. So in case of chronic cachectic state, chronic malignant or cachectic state, as this is a inflammatory state and chronic state, the albumin will get lower because it is a negative phase reactant, right? So these three are the causes of this type of effusion. That means the oncotic pressure is less. Second one, where the hydrostatic pressure is more. That means it is pushing the fluid from the capillary to the interstitium. So any idea what may be the conditions where the hydrostatic pressure is more? One is congestive cardiac failure. In congestive cardiac failure, there is more capillary pressure, more hydrostatic pressure that pushes the fluid outside the capillary into the interstitium, and there accumulates the pleural fluid. Okay. Third one is leaky capillary. What is meant by that? That means if there is pleural infections or parenchymal infections that affects the capillary and capillary become leaky because of the chronic inflammatory state, inflammatory conditions. There are different types of reactive oxygen species formation and inflammatory cells which actually destroys the capillary barrier and makes the capillary more leaky. So the fluid inside the capillary normally leaks out from the capillary. So this is because of the chronic infective state, right? So this is exudative effusion, and the previous two are the transudative effusion because of the hydrostatic pressure and oncotic pressure. Previous two are the transudative effusion, and this type of effusion that is caused by the infection or malignancy, they are the exudative effusion, right? So because of the leaky capillary endothelium. And other mechanisms such as, you know that the interstitial fluid actually clears by the lymphatics. So if by any reason the lymphatic is being blocked or obstructed, such as in case of lymphoma, malignancy or mechanical obstruction of the thoracic duct, that means the pleural fluid cannot be cleared by the lymphatic channel, that also causes the effusion. Okay, this is the fourth reason of pleural effusion. Fifth one is, suppose there is direct trauma to the pleural space and intercostal injury is being injured, intercostal artery is being injured or vein is being injured. So the blood directly leaks into the pleural space. That causes hemothorax. That causes hemothorax. Most commonly after trauma, road traffic accident or any kind of trauma or rib fracture, where the cut edge of the cut end of the rib punctures the intercostal artery, right? And this is another one. If suppose if there is hepatic hydrothorax, what is hepatic hydrothorax? That means if there is massive ascites inside the abdominal cavity and it is under tension, so the fluid inside the peritoneal cavity tends to go upward. We all know that both the diaphragms have got pores, small pores, but right diaphragm has more number of pores than the left diaphragm. So, in case of hepatic hydrothorax, where ascites is present along with pleural effusion, there may be right-sided pleural effusion, not left-sided. This is the main reason is because of the chronic decompensated liver disease, right? And if there is, so I have already mentioned about the leaky capillary and leaky endothelium because of the parenchymal infection. But what happens if there is direct pleural infection? In case in between the pleural space there is direct seeding of the bacilli. That leads to empyema, pass inside the pleural cavity. So this is another reason of the pleural fluid accumulation. And so this is the mechanism. This is very important. This is very important. এরপর নেক্সট যে ডিসকাশন গুলো হবে তার বেস কিন্তু এটা। সো এটা যদি তোদের কোনো কোয়ারি থাকে এই স্লাইডে, ইউ ক্যান আস্ক। দিস ইজ ভেরি ইম্পর্টেন্ট, দিস মেকানিজম, রাইট? ওকে, সো তোর কাছে কোনো পেশেন্ট আসছে, পেশেন্ট এলো, আউটডোর ওপিডিতে তুই বসে আছিস। সো হোয়াট মে বি দ্য ক্লিনিক্যাল ফিচার্স from where you can assure that this is we are dealing with a case of pleural effusion. First is clinical feature. So you should ask the clinical feature. First one is chest pain. So chest pain may be present or may not be present. This is variable. Okay, why variable? Because chest pain most commonly in case of pleural effusion are pleuritic nature. That means the pleuritic, what is pleuritic chest pain? That means the chest pain that is originating from the friction of the two pleura surface. That is sharp in nature, increases during coughing and forceful inspiration. Right? So this is pleuritic chest pain. But একটা খুব ইম্পর্টেন্ট থিওরি হচ্ছে pleuritic chest pain is not always present in case of pleural effusion, because when there is small amount of pleural fluid or the pleural fluid is originating by the infection itself, that means there are exudates inside the pleural space and the pleura is thickened, there is a chance of pleural friction because of the exudates and because of the thickening of the pleura. But in other, this is in case of infective pleural effusion. So pleuritic chest pain most commonly occurs in small pleural effusion or infective pleural effusion. Why small? Because if suppose there is small amount of effusion, very small amount of effusion, so the pleura can actually the friction of the pleura can happen. But if there is more number of pleural fluid, the pleura gets apart. দুটো প্লুরা সেপারেট হয়ে যায়, তখন ফ্রিকশনের কোনো চান্স নেই। সো দেয়ার উইল বি নো প্লুরেটিক চেস্ট পেন। সো this is actually very important consideration, that if a patient of massive pleural effusion develops pleuritic chest pain, that is rare in case of massive pleural effusion, because pleura তো অ্যাপার্ট হয়ে গেছে, তাহলে ফ্রিকশন হবে কোথা থেকে? That means the pleural fluid is decreasing, right? যদি প্লুরাল ফ্লুইড ডিক্রিজ করে তাহলে তো প্লুরাল ফ্রিকশন হওয়ার চান্স পাবে, তখনই পেন অ্যারাইজ করবে। ওকে, সো মোস্ট কমনলি there is one is pleuritic chest pain and another one is most common chest pain is dull aching chest pain in case of pleural effusion. And importantly, কখনো কখনো পেশেন্ট বলবে that the patient's pain is referred from the chest to tip of the shoulder. Why? Because of if the pathology is involving the diaphragmatic pleura, the phrenic nerve is involved and the referred pain to the tip of the shoulder. Second one is cough. So actually cough may be dry in nature because of the inflammation of the pleura, and the vagal afferent fibers are irritated by the infections that induces cough. Most commonly dry in nature. And yes, if the pleural effusion is due to infection or pneumonia, then the cough may be productive in nature. So dyspnea or shortness of breath. In case of in case of mild effusion, there may be no dyspnea. But when the effusion is massive, that hampers the VQ, ventilation and perfusion, and the sudden accumulation of pleural fluid that causes the eversion of the diaphragm. So diaphragm is C-shaped, right? If there is more amount of pleural fluid inside the pleural space, then the diaphragm will be flat and everted. So that sudden eversion of the diaphragm causes respiratory distress, shortness of breath. Now examination. So in inspection, bulging of the unilateral hemithorax, where the hemithorax that is affected by the pleural effusion. Suppose there is a left-sided pleural effusion. So left hemithorax may be bulged or may not be. Mind it, bulging of the hemithorax only occurs in case of moderate to massive pleural effusion, not in small amount of pleural effusion, right? Decreased, definitely there will be decreased movement of hemithorax, and this is also important in inspection. In every case of pleural effusion, you should inspect the chest thoroughly. You have to find if there is any dilated vein present or not. So what does that mean? If the patient is having pleural effusion, shortness of breath and dilated vein, dilated vein at the anterior chest wall, that means the patient may have superior vena cava obstruction due to malignancy, lung malignancy, and that is causing also pleural effusion. Okay, so this is very important. From inspection you can find. And JVP also, in this case, JVP also may rise. But in case of superior vena cava obstruction, the JVP rise will be non-pulsatile. JVP will be engorged but non-pulsatile. So palpation, in palpation, there may be tenderness if the pleural effusion is hemothorax, is due to rib fracture, then the local tenderness will be there. Okay. Second one is local temperature may be also elevated. Why? So local temperature may be elevated only in case of pleural infection, direct pleural infection, in case of empyema. If there is pus inside the pleural cavity, then only the local temperature may be elevated. And the spino-scapular distance, তোদের মধ্যে practical এখনো respiratory medicine হয়নি, তখন আমি পড়াবো, তখন বলে দেবো what is the distance between the spine and the scapula. This is called spino-scapular distance. This is altered in case of pleural effusion. Vocal fremitus, জানিস কিভাবে দেখি? What is vocal fremitus? জানিস physiology-তে হয়েছে. So vocal fremitus will be decreased at the affected site, definitely. And in auscultation, vocal resonance also will be decreased. This is important. In case of each and every pleural effusion, you have to find the position of the trachea meticulously. Why? Because trachea more or less will be central in case of mild to moderate effusion. But if there is massive effusion, due to pushing of the hemithorax, the trachea will be shifted to opposite side. This is normal in case of massive pneumothorax or massive pleural effusion. But in a case of massive pleural effusion, if the trachea is central in position, that means the massive effusion itself pushing the trachea opposite side, whereas there is any pulling pressure, that means there is any underlying collapse by lung mass obstructing the bronchus. Suppose there is a lung mass obstructing the bronchus, there is definitely rise of negative pressure. তাই তো negative pressure create হচ্ছে, the bronchus যদি একটা obstruction থাকে, that means there is a negative pressure, and there is positive pressure due to the effusion. So that two opposite pressure nullifies each other and the trachea is central. Very importantly, if you find that a patient is having massive pleural effusion but trachea is central, you must evaluate thoroughly and check for any obstructive malignancy. Obstruction inside the bronchus, that means most commonly malignancy. Definitely in percussion there are different types of dullness, stony or ruddy, but you may or may not mention this type of dullness. Stony dullness actually would be there at the affected site, right? But there are two important triangles. One is Garland's triangle and another one is Groco's triangle. So what are that? So এই picture দেখতে পাচ্ছিস এই ছবিটা? Suppose this is an area of pleural effusion. This is the right sided effusion, right? So this is dull, this area is dull, whereas this triangular area just above the upper border of the effusion, just above the upper border of the effusion will be resonant because there are compression atelectasis above the massive effusion. So effusion area is dull and just above the effusion is resonant. This area is called as Garland's hyperresonant triangle. Whereas in opposite side, in left side, just opposite to the dullness, along the spinal area, lateral part of the spine, there is another area of dullness. Because of the, suppose there is a effusion and the diaphragmatic pleura and the other parts of the pleura, কি হয় pleura গুলো reflected to the opposite side. So that is this triangle is a pleural dullness. মানে এই সাইডে যে pleura that reflected to the opposite side. So this is called Groco's dullness triad. One is Garland's hyperresonant triad and this is one is Groco's dullness triad. Definitely shifting dullness will be, shifting dullness কোথায় শুনেছিস? Primarily in ascites, not in ascites, in free ascites, not in loculated ascites. Same as in case of pleural effusion. If the effusion is free, not loculated, then there will be shifting dullness. Another important one, S-shaped curve, that is actually mentioned by Ellis scientist. So Ellis S-shaped curve, that means the dullness, মানে তুই যদি dullness পারকাস করতে যাস, suppose the patient is having dullness in from the fourth intercostal space anteriorly. So fourth intercostal space, axilla to fourth intercostal space, posteriorly তুই দেখবি dullness, মানে just S-shaped একটা dullness পাবি. This is also in case of typical pleural effusion, not in case of loculated effusion. So in auscultation, there will be diminished vesicular bed sound, vocal resonance will be decreased, and pleural rub will be there. If pleural rub, that means the pleura rubs with each other. That means if the pleural effusion is due to infection or there will be mild effusion, then you can find pleural rub. And in case of every pleural effusion, you have to do systemic examination meticulously, other system, because pleural effusion to অনেক reason আছে. The pleural effusion may be due to heart failure, may be due to liver failure, may be due to nephrotic syndrome, right? So the pleural effusion may be associated with any enlarged lymphadenopathy that you cannot miss. That may be the clue, right? So meticulously do other system examination. Now, to confirm the presence of effusion, radiology will help, right? The most important radiological investigation is chest X-ray, PAVU. That is most affordable and you can do, right? But the most sensitive one is ultrasonography thorax, USG thorax. So ultrasonography thorax, USG thorax can detect as small as 15 to 20 ml effusion. Okay, so USG thorax is the gold standard to find the effusion. But definitely X-ray is widely available, and in X-ray PAVU 175 ml of effusion, actually 175 ml of effusion যখন minimum pleural fluid level of 175 ml থাকবে, তখন there will be CP angle blunting, costophrenic angle blunting. This is the first sign of effusion. minimum 175 ml of fluid. And a lateral decubitus, x-ray জানিস কিভাবে করতে হয়? সো যেদিকে ইফিউশন আছে সেদিকে পেশেন্টকে শুয়ে দিতে হবে, ঘুরিয়ে। দিস ইজ ল্যাটারাল ডিকুবিটাস। সো ল্যাটারাল ডিকুবিটাসে ইফিউশনে কি হবে, মিনিমাম অফ 50 ml of effusion, 20 to 50 ml of effusion we can detect. But as I have already mentioned, in USG thorax 10 to 15 ml effusion, minimum of 10 to 15 ml effusion you can detect. So এগুলো হচ্ছে different types of X-ray of effusion. So this is left sided pleural effusion, right? So আমি কিভাবে বুঝতে পারবো effusion, what are the utilities of X-ray in case of effusion? First one, to diagnose effusion. Second one, to quantify effusion. You can quantify effusion. Is it moderate, severe, right? And definitely the underlying cause can be elicited from the X-ray. সব সময় হতে পারে না, বাট কোনো সময় পারে। So this is typical effusion, typical pleural effusion. Why typical? Because look at the curvature of the lung. So this is the curvature. This is S-shaped, and the upper border of the curvature is directed toward the axilla. তাই তো দেখ, এই যে the upper border is directed towards the axilla. So this is called meniscus sign. Just this is forming a meniscus. This is typical pleural effusion. Okay? খুব ইম্পর্টেন্টলি কিভাবে কোয়ান্টিফাই করবি, is this a mild or moderate or severe massive pleural effusion? So up to second intercostal space. So second, fourth and below fourth, ঠিক আছে, এইভাবে করতে হয়। সেকেন্ড অবধি যদি ইফিউশন আসে, সেকেন্ড কস্টাল কার্টিলেজ যদি ইফিউশন আসে, that is massive. Second to fourth, up to fourth, this is moderate, and below fourth is normal, mild, right? Second to fourth and below fourth. So this is a case of typical pleural effusion, left-sided effusion. Homogeneous opacity that obscuring the costophrenic and cardiophrenic angle, and the upper border of the opacity is directed towards the axilla, forming a meniscus. So যদি patient examiner তোকে জিজ্ঞেস করে যে describe the X-ray, this is the way of describing the X-ray of pleural effusion. Okay, and এটা কি X-ray? First is এখানে তো কোনো opacity নেই, কোনো homogeneous opacity নেই, haziness নেই, কোনো meniscus sign নেই, but still there are effusions because look at these angles, costophrenic angles in both the cases. So কি করে compare করবি, এই X-ray costophrenic angle টা দেখ, this is sharp angle তো, but this is blunting of CP angle. That means in this X-ray there are bilateral effusion, both sided effusion, but that is mild because fourth intercostal space এর নিচে আছে, but both of the costophrenic angles are blunt. ঠিক আছে, bilateral। এখান থেকে এই X-ray থেকে etiology বোঝা যেতে পারে। What may be the etiology of the effusion? That bilateral effusion is very rare, হয় না। So bilateral effusion is most commonly in heart failure. Okay, heart failure and other transudate effusion, in nephrotic syndrome also, in hypoalbuminemia also, all the transudate effusion may be bilateral. And if there is bilateral effusion along with enlarged heart border, cardiac shadow, এখানে যেটা আছে, আমি এক্সরে ক্লাসে আলাদা করে পড়াবো কিভাবে CTR or cardiothoracic ratio দেখতে হয়। So there is definitely increased cardiothoracic ratio along with bilateral effusion. That means this patient is having effusion due to congestive cardiac failure. And this one is left-sided massive effusion, definitely, because whole lung is opacified. And look at the trachea is shifted. ঠিক আছে, trachea shifted হয়ে গেছে opposite side. That means there is only the pushing pressure. There is no pulling pressure, that means there is no obstruction by the lung mass. And this is also effusion because the costophenic angle is blunt, left sided costophenic angle is blunt, but compare with the first image, there is a meniscus sign, free effusion, right? But this is D-shaped effusion. So the shape is kind of D, alphabet D, right? So this is D-shaped effusion, that means loculated effusion. D-shaped effusion means loculated effusion, right? And so these are all X-rays of different types of effusion, but this is an effusion. This is effusion. Any idea, is this effusion or not? Yes, there is an effusion. This is fissure. This is horizontal fissure. So horizontal fissure bulges out. So the fissure, the effusion only inside the fissure area, right? This is actually a patient তোর কাছে এসছে এরকম একটা টিউমার, this is kind of a tumor, মানে first looks like a tumor, right? So তুই ভাবলি একটা টিউমার হয়েছে পেশেন্টের টিউমার হলো, বাট তোর অন্য কোনো কলিগের কাছে গেল, সে একটা মেডিসিন দিল, দুদিন পর এক্সরে করলো, দ্যাট ভ্যানিসেস। হয়তো আমার কাছে এলো, আমি একটা মেডিসিন দিলাম, আমি একটা এক্সরে করে রিপিট করলাম দুদিন পরে, তুই তো বললি টিউমার আছে, তাহলে কোথায় টিউমার আছে? দিস ইজ নট এ টিউমার। দ্যাট মিনস this fissural effusion is predominantly due to heart failure. The early sign of cardiac failure is fissural effusion. ঠিক আছে? So I have given diuretic and the tumor vanishes. This is called vanishing tumor or phantom tumor, right? Okay. So এটা আরো enlarge করে দেখানো আছে. This is a meniscus sign, right? This is meniscus sign. But এক্সরেটা ভালো করে দেখ, এটার কোন ইটিওলজি বুঝতে পারছিস? ভিজিবল তো, ক্লিয়ারলি ভিজিবল, পেছনে যারা আছিস ক্লিয়ারলি গল্প করছিস তো, তোরা কি ভিজিবল হবে? সবাই গল্প করছিস ওখানে, এটা ভিজিবল? পিছনে ওর এই হ্যালো, তুই কি দেখতে পাচ্ছিস? তোকে বলছি, ওই পিছনে তুই গ্রিন যিনি আছে, হ্যাঁ ওর কি এটা এক্সরেটা? ডেসক্রাইব দ্য এক্সরে। শুনিস নি তোরা, কেউ শুনছিস না, পারবি না? ঠিক আছে, বস। So there is meniscus, definitely there is effusion, but regarding the etiology of effusion, there are multiple rib fracture. দেখ রিবের কন্টিনিউয়েশন ফ্র্যাকচার হয়েছে, দেখ দেখেছিস? এই যে এটা রিবের একটা পার্ট, এটা রিবের আরেকটা পার্ট, দেখতে পাচ্ছিস? অ্যাপ্রিসিয়েট করতে পারছিস? এই যে এইখানকার সঙ্গে এই রাইট সাইডের সঙ্গে কম্পেয়ার কর, রাইট সাইডের এগুলো হচ্ছে ইনট্যাক্ট রিব, বাট এগুলো দেখ ফ্র্যাকচার রিব। That means the effusion is due to blood accumulation. This is a hemothorax. Due to RTA or a road traffic accident, the patient is having multiple rib fracture and that resulting in hemothorax. Okay, so after confirming that you are dealing with a case of effusion, then after the provisional diagnosis ki korte hobe, what is the cause of effusion? So you have to do a thoracentesis or pleural tapping, right? So aseptically you should do thoracentesis. Okay, just কি করে তুই কোথায় করবি? just below the highest point of dullness, যেখানে dullness পাচ্ছিস পারকাশন করে 1 to 2 space below, and 5 cm lateral to the spinal area. This is the ideal area of doing a thoracentesis. But importantly কোথায় করবি? upper rib, just under the upper rib or the just above the lower rib? কোনটা? Just under the upper rib or just above the lower rib? Yes, just above the lower rib. Why? Because vein, artery, nerves, these important structures are there just beneath the ribs. Okay, so to avoid injury to these structures, we should prefer the inserting the needle at the upper border of the lower view. So thoracentesis are mostly two types, diagnostic and therapeutic. Diagnostic, definitely you have to diagnose all the cases of effusion, but according to the latest guideline, only in case of if there is bilateral effusion, bilateral mild effusion with enlarged cardiac shadow, that means you are sure you are dealing with a case of heart failure, then there is no point of doing any thoracentesis, right? But in all other cases you have to do thoracentesis. So definitely one is diagnostic, to diagnose the case of effusion, and secondly therapeutic. So therapeutic in certain cases, such as in case of hemothorax, you have to do therapeutic thoracentesis. In case of hydropneumothorax, pneumothorax along with effusion, you have to do therapeutic one. Actually you have to put intercostal tube in case of hydropneumothorax, okay, not doing any thoracentesis. Second one, if you are dealing with a case of empyema, pleural infection, you have to evacuate all the pus from the pleural cavity, because this is a harbor of infection. This is a harbor of infection. So you have to evacuate all the pus. In case of hemothorax, in case of hydropneumothorax, in case of empyema, right? And so these are the major actually indications of thoracentesis. And another one is if the patient is having massive effusion and the patient is having respiratory distress, then to relieve the distress, therapeutically you should drain the pleural fluid. Okay. And what are the contraindications of pleural fluid tapping? One is uncorrected coagulopathy. If the platelet level is less than 50, then you should avoid doing thoracentesis. And if there is local skin infection, small effusion, you should not do any thoracentesis. Okay. Now, okay, this is yes, this is the first. This should be the first one. After doing a thoracentesis or paracentesis from abdominal fluid or any kind of fluid or CSF, any kind of fluid, first one is you should examine the general appearance. Okay, general appearance and odor. This is very important. So what are the different types of appearance? Actually most commonly the effusion is straw in color. If the effusion is clear as glass, that means mostly you are dealing with a case of transudate effusion. And if the effusion is straw in color and deep yellow in color, maybe you are dealing with a case of exudate effusion. But this is always not true. This is a dictum. Okay. Second one is white in color. But the appearance may be white in color. White in color, that means if you are dealing with a case of empyema pus, you can aspirate that pus inside the pleural fluid, or even if there is no pus or no infection, again the pleural effusion is milky white in color. In case of pus or empyema, the effusion will be turbidly white, ghola hobe, turbidly white hobe, right? But in case of chylothorax, that means chyle leaking into the pleural fluid due to thoracic duct rupture. The chyle just leaks into the pleural space. That result in milky white, ekdom just like a milk, এরকম white একটা fluid পাওয়া যাবে. Okay, black in color, that means the patient may have invasive aspergillus, black fluid, or fungal infection, black color fluid. And definitely blood in case of hemothorax, hemothorax and hemorrhagic, both terms are different. Hemothorax, that means pure blood inside the cavity, pleural cavity, and hemorrhagic, that means there is pleural fluid but there are plenty of RBCs. Okay, and the pleural fluid will not clot. The hemothorax will clot, but hemorrhagic effusion will not clot. Okay, so hemorrhagic pleural effusion most likely in case of malignancy, and hemothorax in case of trauma. And odor, feculent odor in case of anaerobic infections, anaerobic empyema, okay, and urine like odor in case of urinothorax. This is another entity, urinothorax. Definitely there is an ureteropleural fistula or any instrumentation that leads to rupture of the ureter and leaks into the pleural fluid. আমি যেটা আগেই বলেছি যে diaphragm is leaky, so any kind of fluid accumulated in the peritoneal cavity can go into the lung. So next one is first appearance and color, then you have to isolate the effusion as transudative or exudative. So what criteria is of transudative effusion or exudative effusion? The name of the criteria is Light's criteria. পড়েছিস Light's criteria? So Richard Light actually invented the criteria. Any one of the below, any one of the three criteria, if satisfied, this is exudative. So what are the criteria? Pleural fluid protein divided by serum protein is more than 0.5. Pleural fluid LDH divided by serum LDH is more than 0.6, or pleural fluid LDH itself is more than 2/3 of the upper limit of the serum LDH. So these three criteria, any one of the criteria, this is exudative effusion, and if none satisfied, this is transudative effusion. এটা খুব ইম্পর্টেন্ট Light's criteria. So there are definitely other criteria, but এগুলো খুব একটা ইম্পর্টেন্ট নয় তোদের জন্য. Pleural fluid cholesterol is more than 60 and ratio of pleural fluid bilirubin, serum bilirubin is more than 0.6. These are the other criteria. ঠিক আছে? So what are the causes of transudative effusion? কি বললাম কি হতে পারে transudative effusion এর cause? Most commonly heart failure, congestive cardiac failure. Second one, nephrotic syndrome. Third one, hepatic hydrothorax, right? Fourth one, আর কি হতে পারে? Myxedema, hypothyroidism. এগুলো most commonly. And exudative effusion, other সমস্ত infective cause, malignant cause হচ্ছে exudative effusion এর মধ্যে পড়ে. So definitely after তো কি করলি না exudative transudative isolate করলি, হয়ে গেল, তাহলে কালার দেখলি exudative transudative করলি. If the patient is having transudative effusion, আর কিচ্ছু তোকে দেখার দরকার নেই, সেল কাউন্টও দেখার দরকার নেই, okay? But if this is an exudative effusion, then look at the cell types. What are the different four main types of cell? One is neutrophil, lymphocytic, eosinophilic and mesothelial cell. So these four types of cell are predominant in pleural fluid. If this is a neutrophilic effusion, neutrophil is more than other cells. That means neutrophil, that means bacterial infection. You are dealing with a case of infection, empyema or parapneumonic effusion. This is called as parapneumonic effusion. The effusion is caused by from the pneumonia. This is called parapneumonic or synpneumonic effusion. Neutrophilic effusion or early tuberculosis. In early tuberculosis, lymphocyte to pore ashe. Early tuberculosis e neutrophil asbe. Okay. Second one is lymphocytic. So lymphocytic, that means malignant diffusion, malignancy or tuberculosis. Okay, these are the most common causes of lymphocytic exudative pleural effusion. Third one is eosinophilic, very rare, but yes, if there is minimum amount of air present in pleural cavity, that means you are dealing with a hydropneumothorax, then the pleural fluid will be eosinophilic. Or if you are dealing with a case of parasitic infection, then this is a eosinophilic. Drug induced effusion, you may be eosinophilic, okay? And last one is mesothelial. Mesothelial exudative effusion, most likely due to malignancy, right? Okay, so next one is, এটা আমি আগেই বলেছি transudative exudative এর ডিফারেন্সটা, protein LDH and glucose, protein LDH isolate করলি, protein LDH দেখার পর তারপর কি দেখবি? Next one is glucose. This is very important. Why? এটা transudative এ অতটা দেখার দরকার নেই, এগুলো exudative এ দেখতে হবে. Because very low glucose, if the glucose is less than 60, very low, that means কোথায় glucose low হতে পারে pleural effusion এ? One is if there is massive burden of bacteria inside the pleura. So প্লুরা তো ব্যাকটেরিয়া তো অ্যাকচুয়ালি গ্লুকোজটা ইউটিলাইজ করে metabolism, right? So that means the bacteria is utilizing the glucose. That's why the pleural glucose is low, pleural fluid glucose is low. So glucose less than 60 suggests the effusion is most likely parapneumonic effusion, pneumonic effusion or complicated parapneumonic effusion, or empyema itself pass inside the pleural cavity. Another one is in case of rheumatoid pleural effusion, the glucose will be low. In case of malignant effusion, the glucose will be low. So these three causes of these three cases, the glucose will be low. So now brief management in case of transudate effusion. Actually effusion তাহলে ইফিউশনের অ্যাপ্রোচটা ক্লিয়ার তো সবার কাছে, কিভাবে ইফিউশন অ্যাপ্রোচ করবি ক্লিয়ার, রাইট? নাও কিভাবে ট্রিটমেন্ট হবে? So if you are dealing with a case of transudate effusion, all effusions are not same definitely, so you should treat accordingly according to the cause. Suppose transudate effusion, heart failure, definitely diuretics দিবি, cardiac overload কমাবি, effusion itself কমাবি, right? In case of nephrotic syndrome or chronic kidney disease patient, dialysis করতে হবে, effusion কমে যাবে. Hepatic hydrothorax or pleural effusion due to massive ascitic tap করতে হবে, paracentesis করতে হবে, and increase the dose of diuretics. And in case of refractory hepatic hydrothorax, বারবার hepatic hydrothorax হচ্ছে after giving the maximum dose of diuretics, তখন portosystemic shunt করতে হয়, that is called TIPS. যখন লিভার পড়ানো হবে দেখবি টিপস বলে একটা প্রসিডিউর, দ্যাট মিন্স portosystemic shunt, সেটা করলে ইফিউশন এবং অ্যাসাইটিস দুটোই কমে যাবে, ঠিক আছে? And exudative pleural effusion, that means one is parapneumonic effusion যেটা বললাম, or empyema. In case of parapneumonic effusion, empyema, all exudative effusions actually must be drained, ঠিক আছে? মাস্ট বি ড্রেন, প্রত্যেকটা ইফিউশনকে কিন্তু ড্রেন করতেই হবে, ঠিক আছে? নাহলে কি হবে, যদি ড্রেন না করিস তাহলে একটা ইনফেকশন ওখানে ইনক্রিজ অফ ইনফেকশন এক নম্বর, সেকেন্ডলি কি হবে, প্লুরাল থিকেনিং হয়ে যাবে, ওই এরিয়া the pleura will be thickened due to chronic infection, inflammation হবে তো ওখানে, pleura will be thickened, ঠিক আছে? So one is parapneumonic effusion, that means neutrophilic exudative effusion with low glucose, with low pH. Okay, this is parapneumonic effusion. You should send, in case of parapneumonic effusion, you should send the pleural fluid for culture sensitivity, যদি কোনো গ্রাম স্টেন বা অর্গানিজমে পাওয়া যায়, ঠিক আছে? So in case of all parapneumonic effusion, antibiotic দিবি, pleural fluid drain করবি. But if the effusion is lymphocytic exudative, and so lymphocytic exudative এর দুটো most important effusion বললাম, one is TB and another one is malignancy. So how to rule out if there is TB or malignancy? একটা এর নাম শুনেছিস ADA বলে, adenosine deaminase, you have heard that name, ADA 1 and 2. There are two types of ADA 1 and 2. So actually আমরা normally একটা ADA দেখি, ADA level দেখি, actually ADA 2 is more important than ADA 1, and ratio of ADA to 1 দেখার আমাদের ওগুলো কোনো মেশিনারি নেই, আমরা ADA plain ADA দেখি. So if the adenosine deaminase level is more than 40 with in case of lymphocytic exudative effusion, then this is a case of tuberculosis. And if the ADA level is less than 40, then this may be a case of malignancy or any other causes, ঠিক আছে? And definitely not only in TB but in case of pleural infections, empyema specifically, pass inside the pleural cavity, the ADA will rise, ঠিক আছে? So যদি ধর একটা পেশেন্ট এলো, তুই অ্যাসপিরেট করে পাস পেয়েছিস, পাস কখনো ADA তে পাঠাতে নেই, বিকজ ADA will always high. So তোকে মিসলিড করবে যে ওটা টিবির জন্য হচ্ছে, বাট অ্যাকচুয়ালি ওটা টিবি নয়, হতেই পারে, নাও হতে পারে. সো ইন কেস অফ অল এম্পাইমা পেশেন্টস, ADA পাঠাবি না, ADA পাঠাতে নেই. Send the pleural fluid or empyema pass itself for the gram stain culture and CBNAT নয়, BACTEC culture, CBNAT নয়, BACTEC culture or FB smear and this Graham-Stein culture. ঠিক আছে? So definitely যদি tubercular effusion হয়, drain out the fluid and start anti-TB drugs. And malignant diffusion আর একটা radiologically malignant diffusion কিভাবে বুঝবি? Suppose if you are dealing with a case of left-sided massive effusion with central trachea, drain out the effusion and do a CT thorax. হয়তো কোনো একটা আন্ডারলাইং মাস পেতে পারিস, ঠিক আছে? And these are the different types. Okay, so this is end of pleural effusion class. Any doubt? প্রচুর বড় টপিক, যতটা কনসাইজলি আমি মানে অ্যাকচুয়ালি প্লুরাল এফিউশন টপিক 1 উইক পড়ানো যায়, প্রচুর বড় টপিক, ভাস্ট, বাট তোদের খুব কনসাইজড ওয়েতে পড়াতে হবে, বেসিক যেটা সেইটুকু তোদের জানার দরকার।